The next condition we'll discuss is Addison's disease or primary adrenal insufficiency. The background of this disease is that it is hypofunction of the adrenal gland and involves the destruction of the adrenal cortex, which leads to deficiency in cortisol, aldosterone, and androgens. The cause of this may be due to autoimmune dysfunction for patients in developed countries, but in developing countries, then tuberculosis is known to be the primary cause. For diagnosis, it is important to differentiate this from secondary adrenal insufficiency, which is when the pituitary gland does not make enough ACTH, which causes less cortisone production from the adrenal glands. Some points of differentiation are presentations that occur in one disease but not the other, such as hyperpigmentation, aldosterone secretion, and symptoms such as weight loss, hyponatremia, hyperkalemia, as well as specific responses to corticotropin stimulation tests. Of the agents available for use, the typical agents of choice include hydrocortisone and cortisone acetate, which are normally administered 2 to 3 times daily, with most of the dose given in the morning and the remainder later in the day to mimic the circadian rhythm. Based on the amount normally produced by the body, the estimated doses range from 15 to 25 milligrams for hydrocortisone and 20 to 35 milligrams daily for cortisone. For cases where adherence may be concerned, then prednisolone once daily can be an alternative. Mineralocorticoid loss can be a concern in primary insufficiency. Fludrocortisone can be used to help supplement this orally once daily if necessary. Deoxycorticosterone can also be used if parenteral intramuscular therapy is needed. Supplementation can help reduce hyperkalemia risk, though for patients who are already taking glucocorticoids at high doses, replacement may not always be necessary. The potential side effects of pharmacotherapy may include many of the familiar side effects with steroid use: gastric upset, edema, hypertension, hypokalemia, insomnia, and thus patients should be monitored regularly on their weight, blood pressure, and ECG. Potential complications of this disease include adrenal crisis and Addisonian crisis, which occur as a result of acute adrenocortical insufficiency and is considered to be a true emergency. It may occur acutely due to increased adrenal requirements, such as stress, surgery, infection, or trauma, and HPA axis suppression from withdrawal from chronic glucocorticoid use can also be of concern. Treatment of an acute insufficiency would be treated with the parenteral glucocorticoids, which include hydrocortisone as the agent of choice and has combined glucocorticoid and mineralocorticoid activity. As patients are stabilized, they may be transitioned to oral therapy, and it would be reasonable for patients with adrenal insufficiency to have access to injectable hydrocortisone or glucocorticoid suppositories for these types of situations.